This will be our final podcast in our series on bone. And in this podcast, we're going to talk about some of the clinical correlations to bone. Before we do that, though, let's talk a little bit about bone remodeling. Osteons, as we've said, typically develop in pre-existing compact bone. Bone is a very dynamic tissue. It's turned over continually, so there's always continual bone deposition and bone remodeling or bone reabsorption. As we said, our complete skeleton is turned over perhaps every 5-6 years. I don't know the exact number, but it is turned over fairly frequently. Osteoclasts, as bone is remodeling, osteoclasts are going to bore a tunnel through compact bone. They're going to form something called a resorption canal. There'll be a cutting cone of osteoclasts, and there'll be a closing cone of osteoblasts that are at these sites of remodeling. So this resorption canal is sometimes called a bone remodeling unit. New haversion systems or osteons will be formed as the bone remodels. So here is the example of mature bone. You can see the concentric lamellae and the haversion canals. Here's this resorption canal that's lined by osteoclasts. When we look at the image this way, it's a little more complex to look at it, but suppose we had a little section of the bone like this and we're looking at bone remodeling. Well, what we talk about is a cutting cone. This leading edge has osteoclasts that are digesting away the formed bone and then hollowing out this cavity. Coming in behind the osteoclast is a closing cone of osteoblasts, which are laying down new bone matrix, forming new concentric lamellae. So you can get a sense that you've got this growing area of the bone. So this is the direction of bone growth. The osteoclasts are hollowing out an area. The osteoblasts are coming in behind it and synthesizing new bone. So you're getting new concentric lamellae. And so when you look at diagrams like this, you'll see these osteons or haversion systems with the concentric lamellae, and you'll see some of these interstitial lamellae. These would be lamellae that are left over as the bone is hollowed out and reformed. And so you can see these growth line reversals. Here would be the new concentric lamellae that are formed, and so areas like this would have been the older interstitial lamellae that don't get hollowed out as this is remodeling. Now, if we look at the histophysiology of bone, as we said, bone serves as a reservoir for calcium storage in the body. Calcium can be delivered from the bone matrix to the blood if levels are too low, or calcium can be removed from the blood and stored in the bone if levels are too high. Something you should remember and keep this in mind as you correlate histology with physiology. Parathyroid hormone secreted by the parathyroid gland raises blood calcium levels as osteoclast activity is stimulated. Calcitonin, secreted by parafollicular cells in the thyroid, lowers blood calcium because calcitonin tends to dampen down osteoclast activity. Osteocytes may also regulate blood calcium levels. Osteocytes have the ability to respond to a mass load on bones, and by that I mean the weight-bearing load on bones. This is what we termed this osteocytic osteolysis. Surprisingly, we don't really understand much about the mechanism of this, but we do want to emphasize that osteocytes may play an important role in calcium homeostasis as well. Bone, as you know, can repair itself after injury. Soon after you break a bone, a soft callus will form that contains loose connective tissue, fibroblasts, and periosteal cells. Eventually, a bony callus will form as osteoblasts invade that soft callus and replace it with bone, and a bone fracture will usually completely heal in 6 to 12 weeks. Another bit of clinical correlations, we can talk about arthritis, and as you know, arthritis is a disease of joints. Osteoarthritis is essentially an inflammation of the joints, and what happens here is there's some type of a trauma to the articular cartilage. The cartilage is injured, it will calcify and eventually be replaced by bone. There may be a single or simple injury, or there could be repeated injuries that are involved in osteoarthritis. As this gets more severe, you get a situation called ankylosis or bone fusion that actually limits the joint movement and you get loss of mobility. Rheumatoid arthritis, on the other hand, is an immune response localized in joints. The immune response damages articular cartilage. Gout or gouty arthritis is a deposit of uric acid crystals in the joints. Those crystals of uric acid also damage the articular cartilage. Another clinical correlation related to bone is osteoporosis. Osteoporosis literally means porous bones. There's loss of bone density, there's a disruption of the microarchitecture of bones, and there's an imbalance between osteoclast-mediated bone resorption and osteoblast-mediated bone deposition. As you are probably aware, osteoclast activity can be indirectly limited by the effects of estrogen. And there are 3 types of osteoporosis that we can define. This type 1, primary osteoporosis, we see that in postmenopausal women as estrogen levels drop. There's type 2 primary osteoporosis that develops later in life, usually in the 7th or 8th decade of life. Women and men can be affected by this type 2 osteoporosis. And there's a secondary osteoporosis which develops as a result of either drug therapy or disease. Now, interestingly, in osteoporosis, the histology is normal. There's just less material. There's less bone material present. Osteoporosis can be treated with diet. If you improve your diet, perhaps take in vitamin D and calcium supplementation. As you are probably aware, hormone replacement therapy has proven to be problematical in postmenopausal women because, as you know, long-term risks for cardiovascular disease are increased with estrogen therapy, as are the long-term risks for breast cancer. Selective estrogen receptor modulators have proven to be useful in treating postmenopausal women. Bisphosphonates have proven to be useful as well. These bisphosphonates induce apoptosis of osteoclasts, and there's now some new research that's targeting molecules that are involved in the development of cells in the osteoclast lineage. It's thought that if you can inhibit osteoclasts from forming, that might be an effective treatment for osteoporosis. Clinical correlations with bone in relation to nutrition, some of these you know about. Calcium deficiency, a significant one is rickets, and in rickets the bone matrix does not calcify properly. Rickets is caused by insufficient dietary calcium or insufficient vitamin D. In children, this can lead to permanent skeletal deformities if the children aren't treated with dietary calcium or vitamin D. Vitamin D, you might remember, is necessary for calcium absorption from the intestine. Vitamin A deficiency suppresses endochondral bone growth, especially in the long bones. Long bones, as a result, may be prone to fractures. You also know that vitamin C is necessary for collagen synthesis, and scurvy is a condition where the bone matrix gets disrupted because bone matrix doesn't calcify normally. You should keep in mind hormones in relation to bone growth. We have talked about parathyroid hormone and calcitonin. These work antagonistically to affect bone growth by osteoclast activity. Pituitary growth hormone, you might realize, stimulates chondrocytes in the epiphyseal cartilage. It will also stimulate osteoprogenitor cells. It turns out that overproduction of growth hormone in infants and in children can lead to gigantism. In other words, you'll get an abnormal increase in the length of long bones. Overproduction of growth hormone in adults can lead to a condition called acromegaly. There you'll get an abnormal thickening of the bones. Absence of growth hormone in children or in infants can lead to dwarfism. Absence of hyposecretion of thyroid hormone can also lead to dwarfism.